It's time for another warm-up review. Let's get going. What artery and nerve are most at risk of being damaged in a patient with an anterior shoulder dislocation? So the main nerve you worry about is the axillary nerve, and what runs with the axillary nerve is going to be the posterior circumflex artery. Now additionally, what other structures might be injured in an anterior shoulder dislocation? So you got to think about the supraspinatus tendon, you got to think about the anterior glenohumeral ligament, and then the glenoid labrum as well. That's considered a Bancart lesion. And then if the posterior lateral humeral head is injured, that's going to be what's called a Hill-Sachs lesion. Next, a 75-year-old man presents with acute knee pain and swelling. An X-ray reveals absence of erosion of the joint space, but there are calcium deposits in the menisci. What is the most likely diagnosis? Aspiration of the joint would be expected to show what finding? So this is what we call pseudogout, and on aspiration of the joint you would see the calcium pyrophosphate crystals, and then on X-ray you might see that chondrocalcinosis with calcification of the menisci. Next, what are some of the inducers of cytochrome P450? So remember, our mnemonic is Guinness, Coronas, and PBRs, and it induces chronic alcoholism. So the G is for griseofulvin, the C is for carbamazepine, P is for phenytoin, B is for barbiturates, R is for rifampin, and then the S in the PBRs, you got to remember the S, is for St. John's wort, and then the last one, chronic alcoholism, speaks for itself. All right, that's it for the review. Let's get to that video.
Hey everybody. In this video, we'll be talking about menstruation and menopause, and some of the medications we use to manipulate them, like contraceptives. We reviewed the basic physiology of the menstrual cycle in the video on the female reproductive cycle. So let's talk about the more clinical aspects of menstruation. We use the term menarche to describe the first menstrual period, the onset of menstruation. The average age of menarche in the US is just under 12.5 years. We cover puberty and the Tanner stages in another video, but I'll just remind you that the sequence of pubertal maturation in girls is thelarche, or breast development, first, then pubarche, or pubic hair development, and then menarche, the first menstrual cycle. In the first few years after menarche, many girls have anovulatory cycles, resulting in irregular periods and irregular bleeding. This is due to the immaturity of the hypothalamic pituitary adrenal axis, which causes inconsistent release of the hormones of the menstrual cycle. The HPA axis will automatically mature and become regular in about 6 years. So if you have a young patient, 13 or 14 years old, and she's complaining of irregular periods, think about anovulation due to this phenomenon. You still need to do a pregnancy test, but consider the possibility of anovulatory cycles. The treatment for anovulatory bleeding is usually oral contraceptive pills to regulate the cycle. There are lots of different terms we use to describe various types of irregular and abnormal menstrual periods. They're being gradually phased out, but you should probably still be familiar with them. Menorrhagia means heavy or prolonged periods. Metrorrhagia means frequent, irregular periods. So menometrorrhagia means heavy, frequent, irregular periods. Oligomenorrhea is when someone has a cycle length greater than 35 days, resulting in infrequent periods. And the opposite of that is polymenorrhea, which is frequent periods because the cycle length is less than 21 days. Dysmenorrhea means painful periods. Secondary dysmenorrhea is when there is an identifiable cause for the pain, like endometriosis or uterine fibroids. Then the primary dysmenorrhea is painful periods without an identifiable cause. These are basically menstrual cramps. And the first-line pharmacotherapy for primary dysmenorrhea is NSAIDs and/or hormonal contraceptives. So let's talk about hormonal contraceptives. Hormonal birth control contains a progestin, plus or minus an estrogen. These work by providing negative feedback at the hypothalamus and the pituitary, which inhibit the release of FSH and LH, and therefore prevents ovulation from occurring. So let's talk about the use of estrogens and progesterones as pharmacotherapy, starting with estrogens. Estrogens are used for hormone replacement therapy and in hormonal birth control, which can be used both for contraception as well as for menstrual irregularities, PCOS, lots of things, not just to prevent pregnancy. but estrogens have some potentially serious side effects which are worth remembering. Estrogens stimulate endometrial proliferation, so they can lead to endometrial hyperplasia, which can progress to endometrial cancer like we previously mentioned. Estrogens can also promote the growth of other estrogen-responsive cancers such as breast cancer. And estrogens increase the risk of venous thromboembolism like a DVT or a PE. You should also know that estrogens are metabolized by the cytochrome P450 system in the liver, and this may lead to some drug-drug interactions, especially with drugs that induce cytochrome P450. You may remember our mnemonic: Guinness, Coronas, and PBRs induce chronic alcoholism. That stands for griseofulvin, carbamazepine, phenytoin, barbiturates, rifampin, St. John's wort, and chronic alcoholism. So in patients taking any of these medications, the P450 enzymes may be ramped up and the estrogens may be metabolized more rapidly, so the birth control pills may not be as effective. Let's move on to progestins. Progestins are found in hormonal birth control, either alone or together with estrogen. Progestins can also be used to treat abnormal uterine bleeding or to oppose estrogen in women receiving estrogen replacement. Progestins oppose the proliferative effect that estrogen has on the endometrium. So in a woman who still has her uterus, if you're starting estrogen for any reason, you always give a progestin as well. And the main adverse effect that we'll worry about with progestin is irregular bleeding. There's more to contraception than just birth control pills, so let's look at the table in your study guide and review the different types of contraception. First, we have the barrier methods, which include condoms, the diaphragm, and the sponge, as well as a few others. In the real world, these are not as effective as the hormonal methods because of user error, but male condoms do offer the best protection against sexually transmitted infections, including HIV. Next, there are the combined hormonal contraceptives, which contain both estrogen and progestin. These include oral contraceptive pills, OCPs, the transdermal patch, and the vaginal ring. Most of the adverse effects from these combined hormonal contraceptives are due to the estrogen component. So this includes things like venous thromboembolism, hypertension, MI, and stroke. And OCPs are also associated with the development of hepatic adenomas, tumors of the liver. That's worth knowing. There are also some contraceptives that contain progestin only. These include the mini pill, the intramuscular injection of depo-medroxyprogesterone acetate, which is commonly known as Depo-Provera, the implant that's inserted under the skin of the arm called the Nexplanon, which lasts 3 years, and the levonorgestrel IUD, known as the Mirena, which lasts for 5 years, which we have talked about previously. All of these can cause irregular bleeding, but the Depo-Provera has some unique adverse effects. It's the only birth control that has been shown to cause weight gain, although it's usually only a small amount. And it has also been associated with mood changes and, importantly, a decrease in bone mineral density. Definitely know that one. Finally, there's a non-hormonal method that you should be familiar with, the copper IUD. This is a long-lasting method. It lasts for 10 years, but it is also reversible. There is a small risk of uterine perforation when the IUD is being placed, and there is an increased risk of acute pelvic inflammatory disease with IUD use, but that really only occurs in the first 3 weeks after insertion. We started talking about how menarche, when menstruation begins, but now we're going to talk about menopause. Menopause is the permanent cessation of menstruation due to the depletion of the ovarian follicles. You're only born with so many follicles, and when they run out, that's it. The median age of menopause is 51.4 years, and menopause that occurs before the age of 40 is considered pathologic. We call that primary ovarian insufficiency. During menopause, ovarian function ceases and the ovaries stop producing estradiol. So the estrogen levels drop, and this produces a variety of signs and symptoms that we associate with menopause. Our mnemonic for the signs and symptoms of menopause is menopausal symptoms wreak havoc, because a lot of women find these symptoms to be really bothersome and intolerable. The M is for mood changes, especially depression. The S is for sleep disturbances. H is for hot flashes, which are also known as vasomotor symptoms. This is the symptoms that women will complain about the most. A is for atrophy of the vagina, which leads to vaginal dryness, and that leads to dyspareunia, which is pain with intercourse. O is for osteoporosis because bone loss accelerates after menopause. And C is for coronary artery disease. The risk of coronary artery disease increases after menopause. Let's go back and talk a little bit more about the hot flashes, or vasomotor symptoms, since those are so prominent and so bothersome. Hot flashes occur in 75% of menopausal women. Patients will have the sudden onset of heat that starts on the face and chest and then generalizes. It's often accompanied by diaphoresis, sweating, and palpitations, and it can be followed by chills and shivering. Each episode lasts for about 2 to 4 minutes, and women can have multiple episodes per day or at night, which can lead to sleep disturbances. So what can we do about them? The first line therapy is to give estrogen replacement, but SSRIs and SNRIs and gabapentin are other options. And some women prefer alternative medicine, herbal preparations such as soy isoflavones, red clover, black cohosh, and vitamin E. But be aware that some of these can be estrogenic, so you may need to avoid them in patients with breast cancer. So be sure to ask your patients about taking any herbal supplements they may be taking. How do you diagnose menopause? Most of the time you diagnose it clinically after a woman's had 12 months of amenorrhea. You don't need labs to make the diagnosis. She's over 40 and her period stopped, that's menopause, or she's pregnant. But if you were to check the hormone levels, what would you expect to see? Well, the ovaries have stopped producing estradiol and inhibin, so you see a low estradiol and a low inhibin. And without that negative feedback on the hypothalamus and the pituitary, you'd also see high levels of GnRH, FSH, and LH. And just because estradiol is low, that doesn't mean that there's no estrogen around. The adrenal cortex is still producing androgens, and the enzyme aromatase is still converting those androgens to estrone in the adipose tissue. So in a postmenopausal woman, the predominant estrogen present is estrone. For a lot of menopausal women, the mainstay of treatment is to give hormone replacement therapy, or HRT. The symptoms of menopause are primarily due to the drop in estrogen levels. So estrogen is the best treatment for the relief of menopausal symptoms. But there are some caveats to be aware of. As I said before, any woman with a uterus should not receive estrogen alone without progesterone. Unopposed estrogen increases the risk of endometrial cancer. Make sure you know that. Any woman with a uterus who is taking estrogen should also be taking progesterone. Next, hormone replacement therapy should only be used to relieve menopausal symptoms and not for the prevention of chronic diseases like coronary artery disease or osteoporosis. We used to give HRT for those reasons. It hasn't been proven to be beneficial. And generally, the rule of thumb is that we use HRT for the shortest amount of time necessary and at the lowest dose that effectively controls the unwanted symptoms. For instance, hot flashes will stop on their own within 4 to 5 years in most women, even without treatment. So for most women, you shouldn't need to use HRT for longer than 5 years. And finally, the contraindications to HRT are similar to those of OCPs: coronary heart disease, active liver disease, or history of breast cancer, stroke, or venous thromboembolism. Now it's time for the end of session quiz. First question: what is a common cause of irregular bleeding in the first few years after menarche? Anovulatory cycles. And what is the treatment? OCPs, or other hormonal contraception. Next, a 21-year-old college student was started on prophylactic antibiotics following an outbreak of meningococcal meningitis at her sorority house. Despite compliance with her OCPs, she has a positive pregnancy test 4 weeks later. What is the most likely cause? One of the common prophylactic regimens against Neisseria meningitidis is rifampin, which is also an inducer of the P450 system, which metabolizes the estrogen in OCPs. So taking rifampin with OCPs can make the OCPs less effective, which can result in an unintended pregnancy. Next, what hormonal changes are seen during menopause? Low estradiol and low inhibin, which means less negative feedback, leading to a high GnRH, high FSH, and high LH. Last one. Why is progesterone used in combination with estrogen during hormone replacement therapy? Unopposed estrogen increases the risk of endometrial cancer. So in any patient receiving estrogen, if she has a uterus, she needs progesterone as well. That's it for the quiz, but we have one rapid fire fact. Hepatic adenoma is associated with OCP use. That's it for now. See you next time. Good luck.